Good morning, everyone. My topic for today's presentation are comparative study of subtenons versus peribulbar anesthesia in a high-volume cataract surgery setup. My objectives are to compare safety of subtenons and peribulbar anesthesia by evaluating the type and rate of complication observed, and to evaluate the time required to achieve optimal kinesia with each anesthesia technique, and assess the comfort level of surgeon during surgeries with each anesthesia method based on the quality of local anesthesia provided. Now, subtenons and peribulbar anesthesia are two commonly used regional anesthesia techniques for cataract surgery. Both methods aim to provide sufficient analgesia, kinesia, and stable intraocular pressure to facilitate safe and effective surgery. Subtenon anesthesia involves the use of blunt cannula, while peribulbar anesthesia uses a sharp needle, each posing unique risks and benefits. Minimizing complications such as chemosis, hemorrhage, and rare events like globe perforation is essential for patient safety. And this study compares subtenons and peribulbar anesthesia to identify which technique offers better safety, faster onset of kinesia, and improved surgeon comfort level in a high-volume cataract surgery setup. Now, the material and methods. Place of study is patients undergoing cataract surgery at the Regional Institute of Ophthalmology, Sitapur Eye Hospital, Uttar Pradesh. Study period is September to October 2024, and study design. This is cross-sectional prospective observational study involving 108 patients divided equally into two groups, each group receiving subtenons and peribulbar anesthesia. In examination, mainly we monitor the complication such as chemosis, conjunctival hemorrhage, globe perforation during and post anesthesia, and assessment of akinesia and time taken to achieve it since first injection regarding surgeon's comfort on 3-point scale, and tracking additional anesthesia requirement if any needed. All patients were screened and enrolled based on the inclusion and exclusion criteria. Informed consent was obtained and detailed pre-operative assessment were performed. In pre-operative evaluation, medical history, we were considered following headings: medical history, visual acuity, anterior segment evaluation, intraocular pressure, and the posterior segment evaluation. And anesthesia assessment, we will see basically the complications such as chemosis, hemorrhage, and globe perforation were tracked, and the time to achieve optimal kinesia was recorded with additional injection noted if necessary. And surgeon comfort scored on 3-point scale. One is not comfortable, second is moderately comfortable, and third one is excellent, excellent comfort level. And the mainly we how to proceed the patient. Mainly, first we have to screen the patient and enroll them. Then informed consent should be taken and history collection should be proper. And pre-operative evaluation should be done under the following headings such as visual acuity by Snellen's chart, anterior segment evaluation by slit lamp examination, IOP measurement should be tonometry or rebound tonometry, posterior segment evaluation by ophthalmoscopy, and the anesthesia administration. We will see here we have to compare the subtenons and peribulbar effect. So 3 ml we have to give the subtenons and 5 ml in the peribulbar. Next we have to monitor the complication in terms of chemosis, hemorrhage, and globe perforation. Lastly, we have to assess the akinesia, record the time to achieve optimal akinesia, and re-administer anesthesia if needed. Lastly, we will see the surgeon's comfort assessment. One is not comfortable, second is moderately comfortable, and third one is excellent comfortable. Lastly, we have to consider the stats analysis. Inclusion criteria, mainly we are considering here age group 50 to 80 years of age, and pre-operative workups should be completed and eligible for the cataract surgery. The type of cataract, we only include the simple cataract here. We all excluded all the complicated cases from this study. And anesthesia suitability, patient fit for either subtenons or peribulbar anesthesia, and surgical settings scheduled for high volume cataract surgery setup. Informed consent should be taken. And exclusion criteria, complicated cataracts should be excluded, as I already said. Other ocular conditions such as patients with glaucoma or corneal pathology or retinal diseases should be excluded. Previous eye surgery, patient with prior intraocular or corneal surgery should be excluded from this study. Systemic conditions, patient excluded with uncontrolled diabetes or hypertension affecting surgery's outcome. Anesthesia contraindication, if any contraindication is present, we should not consider the patient in this study. Not compliance patient, we already excluded from this study. So result, we will see, we have already categorized patient in the 4 age group criteria. First one is 50 to 60 years, second one is 61 to 65, third one 66 to 67, and the fourth one 71 to 80 years. And accordingly, we categorize your patient, how many patients receive peribulbar and how many receive subtenuous anesthesia. For example, 17 patients receive okay, sir. 17 patients receive peribulbar anesthesia in the particular age group of 50 to 60 years of age, and 10 patients receive subtenuous anesthesia in between 50 to 60 year of age group. And 17 patients in peribulbar anesthesia receive peribulbar anesthesia in between 61 to 65 age group, and 20 patients receive subtenuous anesthesia. 50 patients receive 15 receive peribulbar in age group of 66 to 70 years, and 12 receive subtenuous in between 66 to 70 years of age group, and 5 in peribulbar in between 71 to 18 year of age group, and 12 in the subtenuous. So the demographic data shows, as I already discussed in the tabular form. This is descriptive stats analysis of my study. Akinesia grading is 5.19 in peribulbar mean with plus minus 2.42 standard deviation. In subtenuous, this is 4.86 with plus minus 2.92 standard deviation. Time of akinesia in peribulbar is 118.90 with plus minus standard deviation 15.10. And in subtenuous 115.69 plus minus 12.63. Chemosis noted in peribulbar 46 out of the 54 patient and 40 out of 54 patient in subtenuous. Analgesic during block, 17 patient noted no pain, 37 patient with mild pain, and 36 patient in subtenuous with no pain and 18 with mild pain. Analgesia during surgery, 5 in peribulbar with mild pain and 49 in peribulbar with no pain. In subtenuous, 5 with analgesia during surgery noted with pain and 49 with no pain. Analgesia after 1 hour, 49 in the peribulbar group with no pain and 5 with the pain. 46 in subtenuous analgesia after 1 hour noted pain and 8 don't feel pain. This is the data showing already in the tabular form. And comparison of chemosis presence, scatter plot showing the peribulbar group greater variability in the time to achieve akinesia and slight upward trend in the regression line, suggesting an increase in onset time for the patients. In subtenuous group, more consistent onset time with less variability, stable akinesia onset across patients. Key insight, subtenuous anesthesia shows more predictable and consistent result compared to peribulbar anesthesia, and peribulbar anesthesia has more variability and requires closer management to achieve consistency. The stats test result is T-stats is 1.75 and p-value 0.042. That is significant because this is less than 0.05. My discussion is variability in akinesia onset. Subtenuous anesthesia showed more consistent and predictable onset of akinesia compared to peribulbar anesthesia with a flatter regression line. And in peribulbar akinesia exhibited greater variability in onset time, suggesting a need for more precise management. In stat significance, the difference in mean time to achieve akinesia between the two techniques was statistically significant because p-value is 0.0042. And in subtenuous anesthesia demonstrated a significantly faster onset, highlighting its efficacy in high volume cataract surgery setup. Analgesia pattern subtenuous anesthesia provided more stable intraoperative analgesia with fewer reports of pain during the surgery, and in peribulbar anesthesia exhibited greater variability in pain management with some patients experiencing pain during surgery. Complication rate, subtenuous anesthesia had a higher incidence of chemosis compared to peribulbar. This finding highlight the trade-off between faster onset and lower complication rate. Faster onset in subtenuous and lower complication rate noted in peribulbar. So clinical implications is subtenuous anesthesia may be preferred in high volume cataract surgery setting due to its fast.
Please conclude. Yes. Please conclude.
Okay, sir. Due to its faster and more consistent outcome, and peribulbar anesthesia remain a viable option, but may require closer monitoring for intraoperative pain management. Study strength, this study offers a comprehensive comparison of two anesthesia techniques in high volume cataract surgery setup, helping guide anesthesia choice based on the surgical and patient's need. My recommendation is to further research with a larger sample size and longer follow-ups is recommended to validate these findings. And review of literature studies comparing phacoemulsification as ICS shows that both techniques causes change in central corneal thickness and endothelial cell count. Deepthi et al. Found that while both subtenance and peribulbar anesthesia provided a comparable pain control during surgery, subtenance anesthesia resulted in significantly less
Saba, I
pain.
think you conclude because you are, you are supposed to speak for 5 minutes. Time was allotted. And you have already. Yes, last slide.
So these are my references, sir.
No,
Sir,
when
the
you are
last conclusion
when
is.
you are preparing your presentation, you stick to timing also. You just see that you are.
Yes, sir.
It's, you already spoke for 12 minutes. Yes, because we have got less number of speakers, so we allowed you to speak. Yeah. Anyway, you please conclude.
Thank you, sir.
Thank you. You complete.
Sir,
What is
my
your
last
recommendation and what you feel?
So my last
experience?
conclusion is subtenance is better than peribulbar anesthesia because the faster onset of action in subtenance than the peribulbar anesthesia. Because we are we are mainly seeing conducted this study in the high volume cataract surgery setup. So basically we used subtenance anesthesia.
This is your routine practice in your
Yes,
institution?
sir. In my institution.
Subtenance.
Yes, sir. Sir, in around 35 patients, it takes around 2.14 seconds or 2.30 seconds. But in peribulbar anesthesia, it takes around 3 minutes or 4 minutes around. Sorry, sir? For putting cannula, injecting time, sir, subtenance, in subtenance, this is less than the peribulbar. Sir, lower phonics. Yes. Yes.
How to do it. Those who are not doing it, they will have some carry home message. In this theoretical discussion, they won't be able to, it will not be disseminated to other colleagues, those who are not using it. You should have shown at least the technique, how do you do it.
Yes, sir.
Isn't it?
Yes.
It would have been much better. Okay.
How much dose you use?
Sir, 3 ml in subtenance and 5 ml in peribulbar.
Number two, you should have given indications, proper indications. As in squint surgery, it is not advisable.
Yes,
In
sir.
orbital surgery, it is not advisable, right?
Yes, sir.
You should have proper indications.
You
Like
exclude,
pterygium, you can use it.
Yes.
you
Cataract,
exclude
you can
glaucoma
use it.
patients.
Yes, sir.
In glaucoma
In
patients,
glaucoma
it
patient,
is-
you can't use it because you are using the upper fornix.
Yes, sir.
in glaucoma patient, it is better than peribulbar, not?
In
You
glaucoma.
exclude,
Yes, sir, I excluded.
sir, in glaucoma patient, I think it is better than peribulbar. That is a different thing. But otherwise, in glaucoma patient, they exclude from this study. In glaucoma, peribulbar block is more dangerous than.
This is very well, but if you give it is not very dangerous because direction of the hill is away from the front.
Yeah.
It is striking to the rear wall and upper wall of the orbit. If you are giving on the both sides. So glaucoma it is better, definitely. Glaucoma you have chance. In high myopia it is in high myopia, especially when you have a parameter glaucoma, this is the ideal technique for high myopia. In high myopia, you can have low puncture.
Also, when you're converting from phaco, so it's more comfortable to do a subtenance.
Yeah. That's why I told her that you should have at least show the
थोड़ा
technique.
वीडियोस रहने से
Technique attractive बन जाता है बेटा. आपका presentation attractive.
Your topic is very nice, but you should have changed it.
in 5 minutes you can't convey all these things, you know, all discussions, all references.
Yes,
You
sir.
can give the names of the references, not whole story.
Your technique is good. Basically, uses
good
of this from topical. If you are doing a topical phaco and suddenly patient is not cooperating, then it is a very good technique.
During
Very
surgery
good
you can give
technique.
it.
When you want to convert.
During surgery you
yes.
can give it.
That is a very good technique.
You should have given some practical tips.
Some
what,
critical tips,
yeah.
so that
Okay.
those who are listening to it, they can learn something from your, you know, and you next time when you go for this kind of paper presentation,
Come
stick
with the
your
video.
time and you should practice 3-4 times.
Yes, sir.
You must
Time
do
वाला
rehearsal.
ही अपने
Rehearsal करके तब
ठीक है
आना
ना?
चाहिए.
They'll
Okay.
get marks for
They will cut marks because यहाँ तो लोग नहीं हैं, ज़्यादा लोग will allow you.
Okay. Thank